Hi, my name is Francois Prizinski. I'm a doctor of physical therapy and fellow in training from SportsMedicine of Atlanta's Orthopedic Manual Therapy program, which is accredited by the American Physical Therapy Association. I've been invited today by Dr. Bob Duval and Oakworks to have some participation with a discussion for you guys today on vertebral artery insufficiency testing, screening, and some of the current issues that we have. Oakworks has always the clinician in mind, but it is paramount to us as clinicians and Oakworks to all have our patients' safety first. We wanted to first discuss the issues that currently exist with vertebral artery testing in this first section of our cervical spine series. So there's some mixed views in the literature on how best to approach VBI clinical screening and testing. In 2004, and then later revised in 2006, Marjorie et al. And the Australian Physiotherapy Association defined pre-manipulative cervical spine testing and established some minimum standards. Despite poor screening efforts of VBI testing, and we're going to get into those specific tests, translating to very poor sensitivity as a screening test. But nevertheless, the Australian Physiotherapy Association still advocates all practicing therapists perform these minimum standards of testing. Also, our physical therapy schools here in the U.S. are using these same screening procedures as clinical decision making. So we're going to review some of the literature and how best to approach this with some clinical pearls. As we've said, the sensitivity for VBI testing is 0%, which means that there's a very high false negative rate. This is a test that is completely unable to accurately define a subject group that may be at risk. However, the specificity of VBI testing has been found to range from 67 to 90%, which means if the test is positive, then we have to rule it in for the actual condition. But we may in fact be contributing to a worsening clinical presentation. That's not going to be in our best interest. The Australian Physiotherapy Association, been talking about them, minimum standards. So what they are is active cervical rotation to the left at end range held for 10 seconds and looking for symptom changes. And we're going to talk about the 5 Ds and 3 Ns. 10 seconds returning neutral, 10 seconds, contralateral 10 seconds, looking for symptom, and return 10 seconds. Also mentioning that upon returning, a recurrent occlusion of blood flow may occur. Physical therapy schools still teaching this maneuver, the Hall-Pike-Dix maneuver, or the decline position, or modified decline, not taking the patient to full cervical extension, side bending, and rotation, has been mentioned and taught in schools as a means to assess blood flow occlusion representing a positive test. But like I said, the sensitivity is false. It's extremely negative. However, from 1992 to 2004, 13 well-designed studies in vivo using flowmetry, angiography, Doppler ultrasound, and MR angiography all had conflicting findings. Some reporting that blood flow changes in the test position occluded blood flow ipsilaterally, others stating it's contralateral. But one finding was consistently agreed upon, and that was that extension, side bending, and rotation does decrease blood flow to the vertebral artery and internal carotid artery. So yes, it does occlude blood flow, but does it represent our population at risk? Unfortunately, 4 review articles from 1998 through 2007 all conclude that little evidence correlates between blood flow changes and actual symptoms of VBI. Okay? So the most current literature is actually identifying a subgroup of individuals who may be seeking care for neck pain, headaches, and that have already may created some dissection of the vertebral artery and they're walking in to seek treatment from a manual therapy practitioner. These individuals may have some congenital vascular anomalies that our literature is only beginning to define and are far from clinically appreciating. But currently, work by Thomas in 2011 reported findings of headache feature in 81% of vertebral artery dissections and 67% presenting with dizziness, unsteadiness, or ataxia. So 81% headache feature, 67% some sort of neurological finding. So we're going to get into some of that with our clinical pearls because this is some heavy information. Furthermore, according to Cassidy's work in 2008, published in Spine, 80% of vertebrobasilar artery strokes first start, once again, with a headache and neck pain. And they may be coming in seeking care by a manual therapy practitioner first. So here we are with this type of discussion at Oakworks using some of these wonderful products and wanting to make sure that for all patients, our safety is paramount. So for importance of screening, this is really important. So we can't rely on any special test itself to rule this condition out since being based on occluding blood flow to represent a positive test is actually flawed. So where do we go from here clinically? So our clinical pearls for you is to break VBI screening into 3 categories. So this is some referenced material by Thiel in 2005 from the Journal of Manual Therapy. Number 1, we'd like for you to think about history and clinical features of vertebral artery dissection. So history and vertebral artery dissection. Number 2, think of brainstem ischemia, vertebral artery insufficiency. So we have a dissection, we have ischemia, and number 3 is going to be neurological findings, okay? So with number 1, you want to think about the individual who's coming in off the street who may have reported in their history some trivial minor trauma. They're reporting a unilateral head pain, neck pain feature, particularly suboccipital in nature. Here's the clinical pearl. They will describe this as nothing like they have ever felt before. Now you could say, oh, well, I just saw that person on Friday. But this is something, if you've treated neck pain, and I'm talking to a lot of clinicians hopefully out there, this is an individual that if you've been accustomed to treating ducks, you know what a duck looks like, what a duck sounds like. This is definitely not a duck. It's described as sharp, distinct, nothing like you've ever had pain before. That's vertebral artery dissection. Coming in right off the street, they may actually be already dissected. But you're already looking for category number 2, which is some sort of vascular compromise. It's ischemia, brainstem ischemia. So here's your classic 5 Ds that we're familiar with. Dysarthria, diplopia, dysphagia, dizziness, and drop attacks. These are neurologic features that may arise with vascular compromise. Number 3 major neurologic signs we'll definitely take a look at the 3 Ns. 3 Ns are going to be nystagmus, numbness, particularly paresthesia through the face, numbness through the upper extremity, or also upper and lower on the same side, and ataxic gait. Okay? These are going to be our 3 features that we will look for. So 3 features to screen. Now, this is not using a clinical test. This is purely with history taking and also paying close attention to detail in clinical exam. This is not an area that's seen frequently and presents with poor screening methods. If you want to rely on one single test to represent this population is ruled out. But on behalf of myself and Dr. Bob Duval at Sports Medicine of Atlanta and Oakworks, we all feel it's critical to present material to clinicians to educate them and keep the patient's safety in mind. With Oakworks continually researching and producing products with the clinician in mind, with their unique features that we're going to talk about shortly, with the smooth adjusting headrest, firm response foam top tables. We're going to talk about that accurate precision for the end feel that the manual therapist can significantly appreciate. Safety of our patients is priority number one. So hope to see you guys in section number 2. We're going to look at a special test as part of our cervical spine series, and we're going to take a look at cervicogenic headache.